Okay, so All-American Joe is back now. His shoulder's great. His knee is taken care of. His disc bulge went away. But now I don't know what we're doing, basketball season. And he came down on a kid's foot, felt his ankle twist, went to the ground, um, swelled up immediately. And he can still put weight on it, he can still walk on it. But the pain was just too much to finish the game. He comes in the next day. We're going to have him go ahead and lay right on his back right away. He's a little bit swollen, a little bit bruised. He can walk on it, but he can't push off, he can't run, none of that. So we're going to take a little look here. When we're talking about an ankle sprain on the court, first thing we do have to do is just check our Ottawa ankle rules. He has not been to another doctor, he didn't go to the walk-in. Basically, the foot has not been x-rayed. So we always got to rule out that there could be a fracture here. So all I'm doing now, I already know he can put weight on it, so that was one of the rules. If he says I cannot walk on it, that he's got to go get an x-ray. Then I'm just going to palpate on the back side here of the distal tibia to the distal fibula. Those two spots, 5 centimeters up. If he has any tenderness there, that's a positive test. I'm going to just palpate the navicular bone here, make sure he's not tender there, and then the cuboid right back in here. So if he has any one of those 5, he can't put weight on it, he's tenderness back here, or he's got tenderness on either of these 2 bones. Before I even do anything, I'm going to send him for an x-ray on this ankle just to rule out any sort of a fracture. But for this case, everything was good. Then I just want to check his, what we call the dorsiflexion range of motion, that ankle going back. I want to see how he feels there. I'm going to measure that angle, and then I'm always going to compare it to this side because I need to know what's normal. Now, if this is a pretty significant sprain, he's not probably even going to get to neutral. He's just going to go to here, and we're just going to run out of room right there. Okay, so that has to be fixed right away. Then I'm just going to do some different tests here. I want to feel what that joint is like, how that's moving. He tells me that it's a lateral ankle sprain. He's sore out here. That's where his swelling is. I might just come in here for the sake of my hands, just do a talar tilt and assess the ligament over there. Okay, I'll come around this side. So I'm just gapping these lateral ligaments here that hold the ankle. I want to get a feel for that. Might give him a little bit of a Kliger's twist. He's going to be saying ow this whole time. Right, Joe? That hurt. Okay, and I'm feeling for how much motion is there. I would also feel the other side. So I don't know what normal is for him. So we know we have restricted dorsiflexion. We know we got a little bit of a positive test on the inversion ankle sprain. What I like to do right away, there's some research out there that when you have that inversion ankle sprain right there, that we get a little bit of a glide on the fibular head. I'm going inferior and anterior. So I always come in here, they don't like it, but we give a posterior and superior. So I'm taking this bone and I'm pushing it that way. A little glide right there. They don't like that at all, but we want to do it. Probably hurts when it's not comfortable at all. Depending on the situation, I might give him just a little bit of a tallow curl manipulation in the joint to create some movement. Remember, he didn't go into dorsiflexion very well, so I'm going to manipulate that joint. A couple different ways to do it. And then I'm going to give him, depending on the severity, he definitely has to do active ankle pumps on his own. I might give him some circles to do early on. He might have to spell the ABCs with his big toe. He might have to spell Brady is the best physical therapist. That's usually the one I send him home with. So they have to do that. And then if you want to sit up, Joe, then we'll go to like a three-way ankle. We'll keep your legs straight though. And I'm gonna have him work. It all just depends on the severity and how well he's moving. But I might just give him some real easy ankle plantar flexion, just like a calf raise there. Then we're gonna go to some ankle eversion. So now I'm cueing him drive that out right there. Work the fibularis tendons. Okay. And then we're gonna go up and over. Ankle inversion. I usually don't like this one because we're taking them into the direction of the injury, so we will just use our best clinical judgment here. But I'm going to cue you a little bit more down. Drive that thing down. And something like this, we might even just start it without a band. It just depends on how much it hurts with the resistance. But with an ankle sprain that is not extremely severe and does not have a fracture, we want to promote early mobility right out of the gates. So those are the three there. One other one I really like, I think it's very important, is we got to get that ankle dorsiflexion back. So if he can put weight on it, I'm going to show you what we do. If not, I would be using a rigid strap here, telling him to work dorsiflexion, a long seated dorsiflexion stretch. So he's trying to create more dorsiflexion in there. I'm going to cue him to do that 10 times with about a 5-second hold at the end range there. Okay, if he can put weight on it, then we're going to go on his feet and work the knee to wall dorsiflexion. So he's going to come, where would he have the best grip? Maybe come over here, Joe. I'm going to have him put his big toe right against the trim there. His foot stays flat. And he is going to take his knee and touch the wall. And now scoot back a little bit. This time, yep, he can't. He's stuck right there. That's as far as he can go. Now I want to see the other foot. Put your left foot where that right one is. And go ahead. And he's going to take the knee all the way to the wall. So we have a big deficit right there. Okay, we have to normalize that deficit. So I'm going to tell him, go back to your right one. Go a little bit closer and go again. So he needs to find the point where his knee touches and his heel is just about to come off, and that's where he's going to work. And he's going to work that 10 times, and on the 10th one he would hold that for a minute. And every time he does this, he tries to slide that toe back just a little bit more, and we keep working that until we get pretty darn close to matching. Then the progression as he gets better, different balance, different strength, then we'll get into some jumping and things like that to get him back on the court. All good.